Thanks, Dr. Dake. And congratulations again to Dr. Veith for a fantastic achievement on 50 years. It's been a pleasure to be a part of this. So I've been challenged with discussing the STS and SVS classification scheme and the development of our high-risk features. In 2020, mouse button, next. In 2020, we published the reporting standards that were developed by a joint committee of the SVS and STS, looking specifically at the language tailored to the aortic dissection. And this was published in both the Journal of Vascular Surgery and the Journal of Thoracic Surgery. Yeah, buddy, this is not going well. So the question was, how has this refined language helped reporting on type B aortic dissection patients? Well, since the 2020 publication, I've tallied nearly 500 publications on type B aortic dissection, and 70% of those have referenced a reporting standards document. We consider this a monumental success in terms of finding a common language that we can use to describe this pathology. So what we didn't anticipate doing when we convened this group of excellent writers was to come up with a new classification scheme, but it organically developed within the committee as a strong need because there was a difficulty in really honing in on how we describe aortic dissection. We know about the classification schemes regarding the DeBakey and the Stanford classifications, both of which are commonly used today and will continue to be used. However, there are some shortcomings with respect to these in that they're not endo-intuitive. They really don't localize entry tear location. The extent of the dissection is very non-specific, and also the aortic arch remains ambiguous in the context, of aortic dissection. Yeah, I keep hitting that button, darling, it don't work. So, what we devised was a new classification system that really regionalized the entry tear, and the location of that entry tear was what we call type A versus type B. So if the entry tear is in zone 0, it's a type A dissection, clear and simple. If the location of the entry tear is not in zone 0, it's a type B dissection. So let me elaborate a little bit further. The zones of involvement can be better defined both proximally and distally with this classification system. The arch involvement is no longer obscure and a simplistic yet more descriptive analysis of a dissection that can be relayed to you. Now, with respect to type A dissection, it is a single subscript, and that is the distal extent. And with type B dissections, there's a proximal and a distal extent, as you would expect. And there's an indeterminate classification when that dissection or that tear cannot be identified. So here you see a patient with an entry tear in zone 0. Well, that's a type A dissection. The distal extent is zone 9. This is simply an A9. So you know where the entry tear is, you know it's a type A dissection, and you know its distal extent. It's very easy. Now, with respect to this, and this was a very common presentation, you have an entry tear that's not in zone 0. It is distal, and therefore it is a type B dissection, but it has a proximal extent of zone 1 and a distal extent of zone 9. This is simply a B19. So you could close your eyes, someone tells you that you have a B19 dissection in the ER, you know exactly what that is in your head, an instant mental picture. Now, how about this? I'll throw you a curveball. So here you have a dissection where the entry tear is not in zone 0. It originated as a B. Therefore, it is a type B dissection with retrograde extent into zone 0. So it's still a type B dissection, but this is a B09. So at least we're true to where the dissection originated, and then you could tell where the pathology has propagated. So all in all, I think its practicality and ease to implement is endo-intuitive in nature. Arch is no longer ambiguous, and it allows precise descriptions on the extent, remaining true to the origin and nature of the dissection's origin. Now, with respect to presentation of dissection, complicated versus uncomplicated, We looked at complicated as rupture and malperfusion only in the most serious and most dire circumstances, and uncomplicated is on the other end of that spectrum. No malperfusion, both clinically and radiographically, no rupture, no high-risk features. And there are variations that we have come up with in the literature that confuse uncomplicated. So we intended to just get rid of that, create two spectrums, one uncomplicated and one where it's complicated, and then in the middle we've created this high-risk group with features that portended poor prognosis, such as refractory pain, hypertension, effusion, et all of these high-risk features are going to be discussed further today in the afternoon session, so I won't steal my own thunder. But in conclusion, we offer you a new realm of focused investigation in terms of high-risk features and its early management and natural history of these patients, along with who warrants early intervention. So in conclusion, the reporting system has been widely adopted, the classification system has become mainstream, and the high-risk category is a new frontier of type aortic dissection research. Thank you very much.